begin this with a quote from my mentor, Dr. Rajiv Soman, who says that we live in a sea of microbes. We see infections day in and out, and it is one of the most common clinical conditions which, as clinicians, whether it's physician or surgeons, we all face. So infectious diseases, in fact, has cut across the usual boundaries. The most interesting thing about infectious diseases is that most infections are potentially curable. We have to diagnose them early, accurately, and treat it appropriately. And the management, from the most appropriate management and its closest alternative diagnosis or the management, is very, very wide. And this is very rewarding as well as challenging when we are dealing with infections. So for diagnosis and arriving at a particular conclusion, we do so many investigations. And in our clinical practice, it's very important to interpret them appropriately as well. And this is the theme for today. So we begin this session with the session on diagnostic stewardship. And for this, I request Madam Dr. Richa Diwan to moderate this session. Madam is a senior consultant in Sir Gangaram Hospital. She has been a professor in the Department of MAMC and has so many years of experience. I request her to start the first session. Online है, वो हो जाएगा. It's already there. No, ma'am. Program है ना. Is he online? He is online as well. He's online. And yes, and plus we have the. I can introduce him. Yes. I have this thing. You have it. Huh? Yeah. Huh? Yeah, please.
Good afternoon, ladies and gentlemen. We start the first session after the poster presentation. For this, the topic is diagnostic stewardship. It's a new concept that has come up after WHO started looking at the global antimicrobial resistance. So they have, it's a concept in which they want that the treatment of the patient should be based on the lab testing, and it requires a very close hand holding between the clinicians and the lab people. When the patient comes in with suspected infection, the clinician makes a quick assessment. He orders the correct type of investigation, and the samples are corrected appropriately. And once the samples are sent to the lab, and the lab then gives a quick result, appropriate result with sensitivity, etc., so that then clinician can change the treatment even if he has started something empirically. The whole exercise is driven towards giving a good optimal clinical result as well as preventing the antimicrobial resistance. So with this, I introduce our speaker who is going to talk on the topic. He is Dr. O.C. Abraham, who has been the former president of Clinical Infectious Disease Society of India, and he is professor of medicine at CMC Vellore with more than 30 years of experience, both in internal medicine and infectious disease. And he has been working in the field of HIV. And he has many laurels to his name, which are not listed here, which we are all know of. So I invite Dr. Abraham to start his talk on diagnostics stewardship. Dr. Abraham.
Good afternoon, friends. The organizers of Delhi CIDS chapter inaugural meeting have asked me to speak on diagnostic stewardship. Before I begin my presentation, let me express my thanks to the organizers of Delhi CIDS chapter, specifically Dr. Neha Gupta, for this invitation. It's indeed my honor and privilege to be here today. When I learned medicine and infectious diseases, I was taught three clinical pearls, which I tried to share with my students. These pearls are about diagnostic testing in clinical medicine, not specific for infectious diseases, for medicine in general. Most importantly, and firstly and most importantly, the fact that no laboratory test is perfect. Clinicians and lay public both have a mistaken impression that the positive test result means presence of disease and negative test result means absence of disease, or in other words, a binary. So it's very important to understand that very few tests give us results in a binary format. Most often, test results help you to assign a probability, makes the presence of disease more likely if the test is positive, and if the test is negative, the disease is less likely. So it's always better to think like that rather than yes or no, disease present, disease absent. Second thing is that whenever you order a laboratory test, please remember that you should be ready to deal with the results. Always ask yourself the question, knowing the result of this test, will it help me in managing the patient better or will it change the management? If the answer is no, please do not order the test. Last but not least, treat the patient and not the laboratory test. Today, we live in exciting times, especially in the field of infectious diseases. Advances in molecular biology have given us many rapid diagnostic tests, and this slide gives you many examples of that: PCR, microarray, MALDI-TOF, DNA FISH, and the list goes on. These tests have the potential of revolutionizing the management of infectious diseases. They can give you a faster diagnosis, a very accurate diagnosis. But there are also many challenges associated with the use of these diseases, especially when they are ordered indiscriminately. So my presentation on diagnostic stewardship will concentrate on rapid diagnostic tests in infectious diseases. Will it help in making the management of patients with infectious disease conditions better? So this is the outline of my presentation. First, what is diagnostic stewardship? I'll try to define the term. I will present a case we had the privilege of looking after, where these kinds of tests help us in confirming the diagnosis and led to a good patient outcome. I will look at the available literature. It's not an exhaustive literature review, basically looking at the clinical impact of these tests. And finally, my suggestion on the way forwards. So what is diagnostic stewardship? This is a definition from WHO. This is a coordinated set of interventions, and they're meant to improve appropriate use of microbiological diagnostics to guide therapeutic decisions. So microbiological diagnostics to guide therapeutic decisions. So they should promote appropriate and timely diagnostic testing, and this includes specimen collection, pathogen identification, accurate and timely reporting of results. And this will guide patient treatment. Finally, all this will lead to safer, more effective and efficient patient care. So patient leaves the hospital well, care is effective, and efficient utilization of resources. I'm a clinician. My perspective will be that of a clinician, and so this is a view from outside the lab. ECMID had some concern about the use of diagnostic stewardship. It's very good that you read this commentary. So I'm talking about improving the diagnostic process for antimicrobial usage specifically, not the pre-analytical, analytical, and post-analytical issues associated with the laboratory test. First, I will present this patient. This was an 18-year-old male we saw about a couple of years ago. He presented with fever and headache for 3 days, followed by altered mental status for 1 day. He had become very drowsy, disoriented, and unresponsive. When we saw him in the emergency department, he was febrile, he was tachycardic, tachypnic with a blood pressure of 120 over 60 millimeters of mercury. And he had this particular lesions distributed over his lower extremities. His GC score was 12, E4, V3, and M5, and there was neck stiffness present. So we had a diagnosis of acute meningitis. His CSF analysis was done. It showed neutrophilic pleocytosis. Protein was markedly elevated to 700 milligrams per deciliter. Glucose was 61 milligrams per deciliter. Gram-stain showed many pus cells and no bacteria. Culture was no growth, which we got about 48 hours later. So we were kind of worried about what could be the causal etiology. Thankfully, we had a PCR available, which confirmed the presence of Neisseria meningitidis. He was treated with appropriate antibiotics, got well, and was discharged well. So here, molecular test availability helped in management of the patient, and we had a good outcome. So over the next few minutes, I will briefly look at the published literature to look at the clinical impact of these kinds of tests in the practice of infectious diseases. Basically, I will be looking at utilization, consequence of the results of these tests, and finally, whether they are effective or not. This study, published in 2019 in Frontiers of Neurology, looked at the utilization of syndromic panel for meningoencephalitis. This is a single center study, a retrospective chart review. They introduced this multiplex panel for meningoencephalitis in their hospital, in their center. And during the study period, 705 patients underwent this test. And clinicians looked at these charts critically using a predefined set of criteria. So they found that only about 68% of these 705 had a clinical suspicion of CNS infection. In other words, nearly a third of the patients, the test was done in patients with little or no suspicion of CNS infection. In other words, the pretest probability of acute CNS infection was low or extremely unlikely, and yet the test was ordered. And only 6.4% of the tests turned positive, and it was clinically insignificant in more than a quarter, 27%. So mindless ordering of tests or overutilization and clinical insignificant result in a substantial number. Next, I will turn my diagnosis to non-culture diagnostics of invasive candidiasis, an extremely good review by Dr. Cornelius Clancy from Pittsburgh, published in 2018. This is a review. This is looking at the use of beta-D-glucan and PCR for diagnosis of invasive candidiasis. We know that candidemia and invasive candidiasis are rare diseases. In any hospital patient whom a blood culture is drawn, the prevalence is estimated to be way below 1%, 0.1%. Patient admitted to the ICU, around 1%. We know that Dr. Chakrabarty's multi-centric study published a couple of years ago, the incidence of candidemia in ICU patients was less than 7 per 1,000. So very congruent with this article. In febrile neutropenia, 2%. Septic shock with more than 3 to 7 days in the ICU, 3%. And if you fulfill all the criteria for the prediction model, it's 10%. So candidemia is a rare disease. So when you use a very sensitive test like beta-D-glucan or PCR, this test has excellent negative predictive value, both these tests. They can rule out, so if the test results comes back as negative, it's extremely unlikely that this patient has candidemia, or in other words, it rules out the diagnosis of candidemia and invasive candidiasis with a very high degree of accuracy. Dr. Ram Gopalakrishnan's study from Apollo Chennai, which was again published a couple of years ago, showed us the same thing. So if the BDG is negative, you can say confidently it's extremely unlikely that this patient has candidemia. What about positive predictive value? Generally, a positive predictive value of 15 to 20% is an actionable threshold when you will think of initiating an antifungal therapy. Remember, antifungals are expensive, drug interactions are issues, toxicity is issue. So positive predictive value of 15 to 20%. Not even febrile neutropenia. So septic shock in the ICU for long periods of time, or somebody who fulfills a prediction model for candidemia. So what are the consequences of molecular diagnosis of candidemia? Of course, at least in some patients, it diagnoses candidiasis, invasive candidiasis earlier than culture, and some whom it will be missed by the culture because these are very sensitive tests. But if you order it every time a blood culture is drawn, you will diagnose a large number of patients whom candidiasis is extremely unlikely. So they are false positive tests because of the very low prevalence of the disease. So if you order every time indiscriminately a BDG or a PCR in a patient whom blood culture is drawn, you're going to make a lot of false positive diagnosis. This will drive extra antifungal consumption, the problem of cost, toxicity, drug interactions, and in the US, you have to report them as hospital-acquired infections. So it's another problem. Now, looking at the clinical impact of these tests, I will review 3 randomized control trials. This was from the NHS in UK. This study was done a few years ago, but was published in CMI in 2020. This was an open label RCT where they compared conventional versus rapid diagnosis. They employed MALDI-TOF in blood cultures. So identification based on conventional methods versus rapid diagnosis utilizing MALDI-TOF. They looked at clinical outcomes. This Kaplan-Meier curve shows 28-day mortality, exactly similar, whether you use a conventional technique for identifying the positive blood culture or you use the used MALDI-TOF. There was no difference in mortality. Of course, microbial identification was quicker when they used MALDI-TOF, no-brainer, and time to an effective antimicrobial therapy as determined by a set of expert clinicians was similar. So although microbial identification was quicker, there was no difference in time to effective antimicrobial therapy or 28-day mortality. Next, I will review 2 studies, primarily from Mayo Clinic in the US. So this is the clinical impact of rapid identification and AST for gram-negative bacillary bloodstream infections. This was a multi-center RCT, 2 centers. Patients whose blood cultures turned positive for GNP. So the blood culture was flag positive. Initial gram stain showed gram-negative bacillus. So they had 2 arms, comparison of standard blood culture and AST, antimicrobial susceptibility testing, versus using this particular platform, Accelerate Pheno test. So for 8 gram-negative pathogens, this identified it and gave AST within 7 hours. So a commercially available platform, but only for a limited number of bacteria, gram-negative bacteria. So it could identify it and give the antimicrobial susceptibility within 7 hours. And the outcome they studied was time to antibiotic modification. One thing I would like to emphasize here is that the standard blood culture practice in that hospital, these centers were MALDI-TOF. So as soon as the culture flag positive, further identification was using MALDI-TOF. And these centers had already established program of antimicrobial stewardship. So the lab will call the antimicrobial stewardship team. The antimicrobial stewardship team will interact with the primary clinicians and then give them expert advice on continuing the same antibiotic, escalating or de-escalating based on the identification and susceptibility. They found that time to modification was faster in the rapid arm. So overall, it was faster by 6.3 hours, but specifically for gram-negative antibiotics by a day. Okay, there was no difference in mortality or length of stay. So this is a Kaplan-Meier curve which shows that effective antibiotic therapy or modification of antibiotic therapy, escalation, de-escalation, all were faster when they use the rapid test. So in a center where there is already MALDI-TOF is the standard of care, already there's an existing antimicrobial stewardship team. This commercially available system for rapid identification and rapid AST had an impact in shortening the duration to effective antibiotic therapy. Another trial published earlier by the same team This is in Mayo Clinic. 3 arms. They had 3 arms. Control arm, where they used the standard ID and multiplex PCR, where as soon as the blood culture turned positive, they used a multiplex PCR panel for rapid identification. And the third arm, so they used the rapid multiplex PCR for identification, and it was combined with the stewardship team. So the result was conveyed to the primary team and the stewardship team, and the stewardship team looked at the results, looked at the patient, and then conveyed their recommendations to the primary treating team. And these are the results. Of course, organism identification was much faster when they used the rapid multiplex PCR. Okay, and escalation of antibiotic therapy occurred much faster when the rapid multiplex PCR was used for identification, and the result was conveyed to the clinician. But de-escalation occurred earlier only when it was combined with stewardship advice. Okay, so although rapid identification occurred faster, there was escalation which occurred earlier. De-escalation occurred earlier only when the rapid identification was combined with expert advice on the choice of antibiotics from a stewardship team. Clinical outcomes like length of stay in the hospital, 30-day mortality, readmission for bloodstream infection with the same organism, toxicity and adverse drug reactions, and blood culture clearance in 3 days, CDIF within 30 days, there was no difference between any of the 3 arms. The p-values were not significant. So having a system of rapid identification alone was not sufficient. Communication and input from an antimicrobial stewardship team is what made the difference here. So in summary, availability of these tests in your center can lead to over-utilization or the practice of mindless ordering, test ordering. So test is available, let's use it. There is no consideration for the pre-test probability. It can lead to overdiagnosis, the candidemia example. So every time if you draw a blood culture, if you order a BDG or a PCR, you're going to overdiagnose candidemia. These tests are very expensive, prohibitively expensive. And better diagnostic tests does not always translate to better patient outcomes. Okay. So what is the way forward? So if you want to translate faster diagnostic test results, so results are available quickly in a timely fashion, and this can lead to improved patient outcome. So what should all be there? Number one, these kinds of tests should be available 24/7, round the clock, throughout the week, throughout the day, throughout the week, throughout the year. So if you batch and do these tests, the clinical utility is 0. Clinicians need guidance on test ordering and interpretation. Okay, this can come from awareness creation, educational activities, comments from the microbiology laboratory. Okay, tests should be ordered based on the pre-test probability. Prompt and directed communication, extremely important. So these results should be communicated promptly and directly to the primary team and the antibiotic stewardship team. Okay, the first study from the Mayo Clinic, which used the commercially available rapid identification test. So the results should be communicated promptly and directly to both the treating clinicians and the AMSP team. And very often input from an AMSP team can lead to more appropriate antibiotic prescription, whether it is escalation, de-escalation, discontinuation, change to oral drugs, a lot of things like that. So I will end my presentation with quotes from 2 authors. One is Dr. Raymond Bartlett, clinical microbiologist, who practiced during the era when conventional microbiology was still holding forth, before the era of molecular diagnostics. So he wrote that when clinicians are faced with the superabundance of academic information and pressure to perform exhaustive, expensive, and clinically irrelevant testing. So the tendency to rule out everything rather than confirm a diagnosis. These tests are more expensive, the better it's going to be, not necessarily. Clinically irrelevant testing, this will mislead the physician into erroneous diagnosis and attendant risk of inappropriate therapy. And finally, what he passionately argues for is a more practical, economical, and clinically meaningful approach, effective and efficient utilization of resources. One of my favorite authors, Dr. Siddharth Mukherjee, the author of Emperor of Maladies and the Gene, he has a small book, The Laws of Medicine. And the first law is a strong clinical intuition is much more powerful than a weak test. I tell this to all my students. Very often what we see in clinical practice today is the opposite. We worship a weak test and we ignore the strong clinical intuition. I'm not saying that we should not embrace it. We should embrace newer technology. We should strive to develop better diagnostic tests, rapid diagnostic tests, accurate diagnostic tests. But blindly ordering these tests is likely to create more problems. So when we embrace technology, let us do it rationally. Thank you once again for the opportunity. I will end my presentation here. Thank you again for patient listening also.
About the diagnostic stewardship, even if we have got a lot of these rapid tests, but then the doctors, the infectious disease doctor has to know which test to order, when to order. So the benefit should go to the patient for the early testing also. And don't do too many extra tests, like he gave the example of Candida. So with these comments, I end up this session. Thank you very much.
You allowed any observations on the dog?
I think we should allow a comment on that. Can I take just 1 minute for the next doctor? I'll give you the mic. Hi.
How are you? Thank you. My observation of the MALDI-TOF when you're doing blood cultures is that you should do both routine standard blood culture as well as MALDI-TOF, because MALDI-TOF will not give you the antimicrobial sensitivity result, whereas the normal, so when you draw bloods and you're going to do it, you do both. And the other thing that I wanted to point out was that the CSF showed blood sugar, CSF sugar of 61, but there was no mention of a simultaneous blood sugar. Maybe she was septic and had hyperglycemia on that account. So because 61 for a meningococcal meningitis is a very high blood sugar, very high CSF sugar. So I just wanted to make these two.